Hello, I'm Kelly Hunt, and I'm the professor and chair of the Department of Breast Surgical Oncology at the MD Anderson Cancer Center in Houston, Texas. I'm going to be speaking about the role of neoadjuvant endocrine therapy in hormone receptor positive breast cancer. These are my disclosures, and I won't be discussing any of these today. The outline is to first discuss the rationale for neoadjuvant therapy and patient selection, treatment duration and evaluation of response, and finally, to touch on new targets in treatment of endocrine therapy resistant breast cancer. Our traditional approach to breast cancer management has always been surgery first, followed by adjuvant chemotherapy and endocrine therapy, except for those with inflammatory breast cancer and very advanced disease. More recently, over the last decade or so, there's been a lot of interest in using the neoadjuvant approach to downsizing the primary tumor, downsizing regional lymph node metastasis, and also eliminating micrometastases that are not yet evident. Using systemic therapy in the neoadjuvant setting can also allow us to assess response to the specific therapies and to improve our options for local regional management. In terms of neoadjuvant therapy in breast cancer, we've learned from many cooperative group trials and international trials that there's really no survival difference between using adjuvant therapy versus neoadjuvant therapy. However, it does decrease the rate of mastectomies that are necessary for patients. It also decreases the incidence of nodal metastasis when you compare studies that used adjuvant versus neoadjuvant therapy. And it also improves outcomes that have pathologic complete response or near pathologic complete response to the therapy. We know that the value of chemotherapy in estrogen receptor positive breast cancer is age dependent. This is data from the National Surgical Adjuvant Breast and Bowel Project trials B14 and B20, looking at tamoxifen versus tamoxifen and chemotherapy. And what we see is that with increasing age in decades, we see that there's less benefit to chemotherapy in older breast cancer patients that have hormone receptor positive disease. In terms of neoadjuvant endocrine therapy as an approach for these patients, this has typically been preserved for patients that are older age, usually over age 70. It's been shown that there are increased local failure rates and similar survival outcomes in these individuals. It's often considered the best option for patients who have a very limited life expectancy and significant medical comorbidities. In the early trials with neoadjuvant endocrine therapy, tamoxifen was utilized as the primary approach. More recently, aromatase inhibitors have been utilized as they've been shown to be more effective than tamoxifen in postmenopausal patients. There have been trials directly comparing neoadjuvant endocrine therapy with neoadjuvant chemotherapy. This is a trial published back in 2007 by an international group showing that postmenopausal women with hormone receptor positive breast cancer, both node positive and node negative with more advanced disease, ER positive and or PR positive, when they were randomized to chemotherapy versus endocrine therapy, and in this case, aromatase inhibitors were utilized, patients then completed surgery, either modified radical mastectomy or breast conserving surgery and radiation therapy. This was a phase 3 randomized comparison that showed no difference in pathologic complete response rates with either therapeutic approach. The rate of breast conserving surgery was slightly higher in those who received neoadjuvant endocrine therapy. And overall, the endocrine therapy was well tolerated. So what about using this as an approach for more earlier stage breast cancer patients? Well, aromatase inhibitors definitely have higher response rates compared to tamoxifen and promote breast conserving surgery in several trials that have directly looked at these comparisons. the aromatase inhibitor could be an alternative to chemotherapy. And so, because there were no direct comparisons between the three AIs early on in the 2000s, we asked the question in the American College of Surgeons Oncology group as to whether we could use neoadjuvant endocrine therapy in the US. Was it feasible, and what were the appropriate endpoints? So we designed the Z1031 study, and this was targeting postmenopausal patients with ER positive disease, strongly ER positive with all red scores of 6 to 8, and a clinical stage of 2 or 3. And we directly compared the three aromatase inhibitors because at this time, the adjuvant trials had not yet completed, showing whether these were biologically equivalent. After 16 weeks of neoadjuvant therapy, patients went on to surgery and then continued AI therapy where possible, and also received other adjuvant therapy, including radiation and chemotherapy, at the discretion of the treating physicians. This shows the clinical response rates to the three AIs, and you can see here that they were essentially equivalent. And this has been demonstrated, of course, in the adjuvant trials comparing the different aromatase inhibitors. But in this neoadjuvant trial, where you can see where the numbers of patients were much smaller, the results were achieved in a much shorter time frame than the typical adjuvant therapy trials. What about surgical outcomes? Well, what we found was that in patients who were thought to be marginal candidates for breast conservation, 83% were able to have breast conserving surgery. In those that were thought to be only candidates for mastectomy, 50% were able to have breast conservation. And even in some patients who were thought to be inoperable, there were some patients who were able to have breast conserving surgery after only 16 weeks of AI in the neoadjuvant setting. We also looked at suppression of Ki67, and all three AIs were essentially equivalent. The patients also, we looked at the baseline versus the Ki67 at surgery, and there were very few cases when the Ki67 increased from baseline to the surgical sample. In fact, most we saw a decline. So can response to neoadjuvant endocrine therapy be used to tailor therapy? The big question is, does a lack of Ki67 suppression identify patients that might be more suited for chemotherapy? And is there an alternative to pathologic complete response, which we typically utilize in neoadjuvant chemotherapy studies? So there is a tool called the PEPI score, and so this is the preoperative prognostic index that was developed by Matthew Ellis and colleagues using data from the PO24 trial. And this includes the tumor size at the time of surgery, nodal status, and the Ki67 level distributed, as you can see here, and also the ER status and all red score. And you can see that recurrence-free survival and breast cancer specific survival are determined by a point system based on these elements of the PEPI score. So what they found was that a modified PEPI 0, meaning that the tumor was T1 to T2, negative lymph nodes, and Ki67 less than 2.7, showed excellent relapse-free survival outcomes, suggesting that these patients do not benefit from chemotherapy, whereas those that did not achieve a PEPI 0 status might benefit from chemotherapy. So the Ki67 has also been explored at 2 to 4 weeks to identify patients that are less likely to achieve a PEPI 0 status. So data from the POL and IMPACT trials showed that a 2 to 4 week Ki67 correlates with the surgical specimen that would be obtained 3 to 4 months later after neoadjuvant AI therapy. And a cutoff of Ki67 of greater than 10%, patients had a chance of PEPI 0 status less than 2%. And 20% of patients will have a Ki67 that's greater than 10% at 2 to 4 weeks of therapy with an AI. So from the Z1031 trial, we looked at recurrence-free survival, PEPI 0 versus non-zero in patients with a median follow-up of 5.5 years. And what we found was the PEPI 0 rate was about 26%. And you can see here that recurrence-free survival in patients achieving PEPI 0 was excellent. And those that did not receive chemotherapy also had an excellent long-term survival with when they achieved a PEPI 0 status. We did see adjuvant chemotherapy use was administered in about 15% of PEPI 0 patients. So how do we increase the PEPI 0 rate? Well, we can, of course, identify alternative endocrine therapies. We can identify pathways that are responsible for resistance, and we can also look at combination therapy strategies. But treatment duration does seem to have an impact as well. So tumor volume does decrease with longer therapy. And this is a study published by Mike Dixon and colleagues showing that there were increased rates of breast conservation when they utilized treatments longer than the typical 3 to 4 months. And so what you can see here is that the change in volume did decrease over time. We also see greater response rates with longer duration of therapy. And this is another publication showing that PCR rates did significantly increase with longer duration of therapy. There are also genomic tools that can help us select patients for neoadjuvant endocrine therapy. So immunohistochemistry is typically utilized to determine the approximated subtype based on ER, PR, and HER2 status, and also looking at Ki-67 score as well. The Oncotype DX 21 gene recurrence score assay has been utilized in the TRAN-NEOS trial, and the MammaPrint and Blueprint assays have been used in the Symphony trial to identify patients that might be more suitable for neoadjuvant chemotherapy as opposed to neoadjuvant endocrine therapy. There are also some alternative endocrine therapy strategies, of course, fulvestrant, which is a selective estrogen receptor degrader. The first study showed that there was an overall survival benefit with fulvestrant versus anastrozole. And also the Falcon study, a phase 3 trial showing improvement in progression-free survival in those with advanced hormone receptor positive breast cancer who received fulvestrant compared with anastrozole. There are a number of pathways that are involved in resistance to endocrine therapies, including tumor microenvironment, of course, the ER pathway and ESR mutations, apoptosis and senescence, cell cycle machinery, EMT and cancer stem cells, secondary messengers, especially those in the PI3 kinase pathway, and growth factor receptor pathways. So in conclusion, neoadjuvant endocrine therapy trials are feasible with relatively low toxicity. The conversion from mastectomy to breast conservation in 50% of cases is a clinically meaningful endpoint and underscores the value of using neoadjuvant endocrine therapy for women with ER-rich tumors who desire breast conservation. Ki-67 at 2 to 4 weeks and PEPI score are measures of resistance to AI therapy. And biomarker and somatic mutation-based stratification are necessary for rational trial design of combination therapies that are currently being explored in clinical trials. Thank you very much for your attention.